So Richard, this sounds like a difficult task. Somebody walks in, they get diagnosed. You want to make sure you have the optimized treatment, the classic medical model, diagnose and treat, but we're bringing an element into this that sounds difficult and requires a sort of it takes a village kind of a philosophy around this. So in your mind then, who makes up the diabetes care team? What are all the moving people and parts that are needed to accomplish this very difficult task as we all describe it?
The care team starts with an MD or provider, a PA, nurse practitioner who's skilled in diabetes management and can speak to the patient about the clinical goals and some interaction with about what your goals are, what's important to you about this. And then the pharmacist is extremely important because they recognize that the patient's not taking this. They are not taking it correctly. They're running out early and they didn't pick this up because of the cost. They can suggest therapeutic substitutions for medications that their insurance plan has changed and now they can't get this. They don't necessarily share everything with the doctor, but they're more casual with the pharmacist they see very regularly. So a lot of information comes that way. Nutritionists and I'd say nutritionist coach, sort of, because understanding the patient and, well, Thanksgiving, what did you have? And that kind of conversation where they're familiar and they understand someone who is living a life and has to negotiate diabetes through that.
So it's interesting, if I take what Darren said and then what you said is that we're sort of setting a care plan for this patient. And the care plan...
Prioritizing their goals first.
Prioritizing their goals.
So is this really someone who is going to change everything and start exercising today and eat this, not that, and take this? Maybe. That's a small subset of patients. The care plan has to include the patient's goals and what's important to you about this.
Okay. So diagnose, regimen, treatment, care plan, which is patient-specific, right? So personalized medicine isn't just about biotechnology. Personalized medicine is about behaviors and motivations and patient goals, et cetera, et cetera.
Yes, I would just emphasize understanding what the patient's goals are, so that's an important part of the conversation.
And so we're setting some kind of care plan. I'm looking at somebody like Tripp who's out there sort of in the field then, right? So you've got this care plan. It seems to me like what you're saying then is one of Tripp's roles and the role of the folks that are around him and his support folks in a community pharmacy is diagnosing when we're off our care plan. Right? So you're sort of setting this holistic care plan. You've got some team members around you, and then they're off into the field, right, as you described. So what happens now when you're not in that 6 to 13 minutes with the patient? We could set a perfect care plan, but it may not be a perfect care plan next week when they're diagnosed with something else, or it might not be a perfect care plan if they can't afford it, don't have transportation, don't believe in it, neighbor says you shouldn't, I saw this. I had a bad side effect, et cetera. So tell me about the sort of the diagnosing when somebody, how do you figure out in a pharmacy, I bet this person's off their care plan. How do you engage that patient and sort of go through that Sherlock Holmes exercise?
So the Sherlock Holmes piece typically is what is the care plan? Because 9 times out of 10, even more than that, probably 99% of the time, we don't have access to whatever that particular patient's care plan is. So, we have to really figure out we have to deduce what's the most likely care plan for this patient, and then what are we seeing. And so we've got some advantages in the community space because we see a lot of blood glucose meter readings. We check blood pressures, and so we can kind of tell when if the blood glucose is high, then obviously something's going on. It's time for us to intervene. So I'm real envious of this relationship here because we don't always have it with all of the providers that we work with, and it makes life so much easier when we can pick up the phone and say, hey, we just took Miss Jones's blood glucose and it was high, and we've noticed that she's not filling her insulin as often as she probably should. What's the care plan? What would you like for us to do to intervene, and would you like for us to refer at this point? That's the ideal world, and we've got that relationship with many prescribers, but not all of them. So that's where we want to be because we can do our job a lot better.
So it's what I hear about what you're saying that's interesting to me is we're starting to go through a renaissance in medical practice about a different type of relationship with a patient. So what does that relationship look like between provider and patient, and how do we involve them in shared decision making and motivational interviewing? But we don't talk about as much as how do we foster relationships between care team members? And if it takes a village to take care of diabetes, what are we doing to foster those types of communications and interpersonal and interprofessional relationships? Most of the interactions might be fax tag over a pre-authorization or illegible handwriting or whatever else. How do we communicate those care plans? Say, here's a care plan we've set for a patient. Please let us know.
To me, it's even bigger because we have to get over this event-based medicine. Like right now, we see all the time when we've got a patient discharged from a health system or a hospital, that was the event, they're out, all of a sudden it's somebody else's problem. And then it goes to the family practice physician. And maybe they haven't seen the patient yet, so we're stuck in between in the pharmacy from two events. One that hasn't occurred yet, which is that family practice visit, the follow-up, and one is a discharge, and nobody's taken ownership for what's going on right now, which is a lot of times some sort of gap or an issue. And so getting there, I think, starts with good handoffs.